concept of mobility refers to purposeful movement including gross simple movements, fine complex movements, and coordination. Asterisk plays an important role every day, and interferes with ADLs. Work environment, home environment, sports, fun and recreation, interactions with others, immobility, inability to move, impaired physical mobility, state in which person has limitation in physical movement but is not immobile, deconditioned, loss of physical fitness. Optimal mobility relies on bones, joints, articular cartilage, tendons, ligaments, skeletal muscle, and mechanics of muscle contraction. Neurological systems. Signals for all movement are communicated to and from the brain from nerve impulses. Musculoskeletal systems. Bones, structural foundation, supports and protects, and provides attachment sites. Joints, provide stability and allow skeletal movement. Muscles, under voluntary control. Muscles, under voluntary control. Consequences of immobility. Asterisk. Cardiovascular complications, central and peripheral perfusion. Lack of physical mobility equals decreased cardiac capacity. Respiratory complications, reduced lung expansion, atelectasis, reduced capacity for gas exchange, pneumonia. Integumentary complications, sustained pressure on the skin, downwards arrow, perfusion to tissues, rightwards arrow, hypoxia, rightwards arrow, increased risk for skin breakdown. GI constipation, urinary stasis, infection, renal calculi. Physiologic, boredom, depression, helplessness, grieving, anxiety, anger, disturbed body image, decreased verbal, nonverbal communication. Assessment for mobility. History, past health history, medications, surgeries, treatments, social age X, presence of pain with movement, recent changes in mobility or problems with balance, presence of fatigue, recent falls, recent changes in ability to complete ADLs. Exam findings, gait and body posture, joint size, symmetry, strength of muscles, 0.5 ROM of joints. DX, CT, X-ray, bone density, blood work for calcium. Clinical management for mobility. Quadriplegia, tetraplegia, paralysis of upper and lower limbs and trunk. Primary regular physical activity, optimal nutrition, healthy weight, adequate rest. Secondary osteoporosis, mobility screening, fall risk assessments. Collaboration, immobilized patient, exercise therapy, PHR agents, surgical interventions, immobilization, assistive devices. Primary regular physical activity, optimal nutrition, healthy weight, adequate rest. Secondary osteoporosis, mobility screening, fall risk assessments. Collaboration, immobilized patient, exercise therapy, PHR agents, surgical interventions, immobilization, assistive devices. Neurological assessment. Interview. LOC. Pupils, paralysis, size, shape. CN nerve testing, phases 7. Vitals. Motor function, 0-5. Sensory function, a knife versus a Q-tip. Tone. Cerebral function. Exemplar 13G, spinal cord injury. Often a result of trauma from a motor vehicle crash, fall, or gunshot wound. More common in MEN. Vertebrae or other objects are forced against the spinal cord, damaging nerve cells, and/or preventing transmission of nerve impulses. Can cause anything from slight muscle weakness, rightwards arrow, complete loss of sensory and motor. The spinal cord transmits sensory signals from the body to brain and motor signals from brain to body. Descending pathways carry motor down to the body. Ascending pathways carry sensory up to the brain. Spinal nerves don't have to memorize this, but I guess be familiar. 8 cervical, C1-C8 nerves, rightwards arrow, controls head and neck and breathing. C3-C5 injury above C3 means the person will probably be on a ventilator. Quadriplegia comes from cervical injury cause everything below is affected. 12 thoracic, T1-T12 nerves, rightwards arrow, controls motor and sensory to thorax and abdomen. Anything above T6 is where you're at risk for AD. 5 lumbar, L1-L5 nerves, rightwards arrow, controls lower back, hip and legs. 5 sacral, S1-S5 nerves, rightwards arrow, controls bladder, bowel. 1 coccygeal, C0 nerves, rightwards arrow. Quadriplegia, tetraplegia, paralysis of upper and lower limbs and trunk. Usually associated with cervical injury. Worried about airway with cervical injury. Paraplegia, paralysis of all or part of the trunk, legs, pelvic organs, full use of arms. Usually associated with damage in thoracic or lumbar region. With sacral injuries, worried about bowel and bladder. Paraplegia, paralysis of all or part of the trunk, legs, pelvic organs, full use of arms. Usually associated with damage in thoracic or lumbar region. With sacral injuries, worried about bowel and bladder. Level of injury, vertical location of the injury along the spinal column. Etiology. Excessive force causes hyperflexion, head down. Hyperextension. Compression of spinal. Rotational injuries. Transection of spinal. Most common causes: motor vehicle crashes, falling, violence. Other causes: sports, diseases, cancer, osteoporosis, arthritis. Hyperextension injuries occur when the spine or neck is bent backward beyond normal limits. Forward bending injuries are called hyperflexion. Lateral flexion or twisting causes rotational injuries, and vertical force to the spinal column results in compression injuries. Hyperextension injuries occur when the spine or neck is bent backward beyond normal limits. Forward bending injuries are called hyperflexion. Lateral flexion or twisting causes rotational injuries, and vertical force to the spinal column results in compression injuries. Spinal cord injuries occur when excessive force causes one or more of the following: hyperextension, hyperflexion, compression, rotation, transection of the spinal cord. Hyperflexion, forward bending beyond normal limits, and hyperextension, backward bending beyond normal limits, are usually caused by sudden acceleration-deceleration forces, such as occur in a motor vehicle crash. During these rapid body movements, the most flexible portions of the spine, the cervical, C5, C7, and thoracolumbar, T12, L1 regions, are likely to sustain damage, including dislocated or fractured vertebrae, torn ligaments, ruptured discs. Mechanics of injury to the spinal cord are shown in the images here. Hyperflexion, often due to diving in frontal motor vehicle crashes. Rotation, in which the head and neck are twisted. Hyperextension, often due to rear-end motor vehicle crashes and falls. Compression, due to falls that put vertical pressure on the spinal column. Infants and young children are at higher risk for injury to the brain and spinal cord because their bones and muscles are still developing. Risk factors for SCI: 80% occurs in males. Engaging in risky behavior. Race, ethnicity, non-Hispanic dumb white boys. Older adults from falling. The biggest thing is prevention with SCIs. Prevent toddlers, older adults from falling. Safe driving. Don't dive into shallow waters or above-ground pools. Appropriate safety gear for sports. Avoid leaning head-on with sports. Initial treatment with SCIs. Stabilize the spine ***** transport with cervical collar. Prevent further damage. Resuscitation. Preserve neural function. ABCs, tracheostomy, vent. IV for lifeline. NG to suction. Foley. Diagnostics: 85% of significant spinal injuries will be seen on standard lateral cervical spine. Check vital signs before sending off for DX. CT scan should be obtained. Most sensitive in spinal trauma, complex patterns and fractures can be understood. Radiographs and CTs are best for significant info. Diagnostic tests for spinal cord injury should include imaging tests such as X-rays, mammograms, CT scans, or MRIs. They are helpful because X-rays can reveal major vertebral fractures and other bone problems. Mammography can allow visualization of damage to the spinal cord and surrounding tissues. Clinical manifestations depend on the level of injury and location. Systems below injury level will be affected by damage to spinal cord. The higher the level of injury, the greater the extent of motor and sensory deficits. Emergency SS. Extreme pain, pressure on neck or back. Weakness, paralysis, lack of sensation. Loss of bowel or bladder control. Impaired breathing after injury. Oddly positioned neck, back. Spinal shock, inflammation of spine. Loss of reflexes below the level.
BPHR 上升
Characterized by spinal cord swelling, decreased blood flow, complete loss of motor function, spinal reflexes, and autonomic function below level of injury. Usually occurs right after injury and can last for several hours, rightwards arrow weeks. During spinal shock, even undamaged nerves may have trouble communicating with the brain, causing paralysis and loss of reflexes and sensations in the limbs that are unrelated to the site of injury. The patient has hypotension, bradycardia, and low body temperature, is incontinent, and has no sensation below the injury. These are all symptoms of spinal shock. Approximately half of individuals with spinal cord injury develop spinal shock, which is characterized by spinal cord swelling, decreased blood flow, decreased blood pressure, complete loss of motor function, loss of spinal reflexes, loss of autonomic function below the level of injury. During spinal shock, even undamaged nerves may have trouble communicating with the brain, causing paralysis and loss of reflexes and sensations in the limbs that are unrelated to the site of injury. Spinal shock usually occurs immediately after injury and can last from several hours to several weeks. During spinal shock, even undamaged nerves may have trouble communicating with the brain, causing paralysis and loss of reflexes and sensations in the limbs that are unrelated to the site of injury. Spinal shock usually occurs immediately after injury and can last from several hours to several weeks. Classifications of SCIs, using Asian Impairment Scale. Complete, involve a total loss of all sensory and motor below SCI. Irreversible damage, loss of sensory, loss of motor, loss of autonomic function. Below level of injury asterisk. Incomplete. Involve a partial loss of sensory and motor below SCI. 7 complications asterisk must know. Impaired mobility. Log roll. Provide assistance to keep alignment, teach care of tractions, collars, splints, braces, assistive devices for ADLs. Flaccid paralysis, low tone, use high-top tennis shoes or splints to prevent contractures, remove every 2 hours for risk of skin breakdown. Spastic paralysis, high tone, prevent spasms by avoiding sudden movements or jarring of the bed. Avoid internal stimuli, avoid full bladders, avoid use of footboards, avoid staying in one position too long, fatigue. Risk of urine flowing back into kidneys. Treat spasms by decreasing causes, hot or cold packs, passive stretching, antispasmodic mids. Monitor for orthostatic hypotension. Assess BP especially when rising. Maybe an abdominal binder to keep it firm. Assess with PT tilt table as individual gradually gets used to being in upright position. Impaired gas exchange, especially with cervical injuries. Airway. Phrenic nerve, C3-5, controls diaphragm bilaterally. If it doesn't function, rightwards arrow, ventilator dependent, tracheostomy. Respiratory rate, rhythm, depth, breath sounds, effort, ABGs, O2 sat. Quad cough, helping them assist with cough as needed. Impaired skin integrity. Assess for skin breakdown and thrombophlebitis. Remove TEDs Q8 hours asterisk and wear them when individual gets up. Change positions frequently Q2 hours. Protect from extreme tan. They can't control their temp. Inspect skin at least 2x day, especially over bony prominences. Avoid shearing and friction to soft tissue with transfers. Nutritional status. Special mattresses. Constipation. Bowels rely more on bulk than nerves. Stimulate bowels at the same time every day, best after a meal. Individual may progress from Dulcolac suppository, rightwards arrow, glycerin, rightwards arrow, gloved finger, digital stimulation for spastic bowel. Assess bowel sounds prior to giving food for the first time. Paralytic ileus. Sacral injuries tend to be incontinent. Impaired urinary. Flaccid bladder. Sacral level asterisk, lower motor neuron lesion won't hold urine, tend to dribble all day long. Skin breakdown risk. No reflex from S2, 3, 4. Autonomic emptying of bladder. Need Foley or frequent intermittent catheterization. Void under low pressure. Spastic bladder, cervical, thoracic, lumbar injuries asterisk, upper motor neuron lesion. Bladder fills and doesn't let urine out, so it goes to a place of lower resistance and causes kidney injuries. Reflex arc but no connection to or from brain. Reflex fires at will. Bladder training. Triggers points to stimulate emptying. Self-catheterization 6x day. Use a bladder scanner to see the amount of urine left in the bladder. Goal residual less than 100 milliliters, 20% bladder capacity. Assess effectiveness of meds. Bethanochol, Yorcoline stimulates bladder contraction. Urinary antiseptic. Ineffective coping. Assess thoughts on quality of life, body image, role changes. Physical and psychological support. Most common SCI is in 1530YO and generally a risk taker. Greatly affects their perception of life. Try to get connected with support groups with others that have SCIs. Autonomic dysreflexia. An SCI above T6 life-threatening. Results in loss of normal compensatory mechanisms when the sympathetic nervous system is stimulated. The abrupt onset of excessively high BP as the result of an overreactive autonomic nervous system. Vasodilation symptoms above SCI, parasympathetic. Vasodilation symptoms above SCI, parasympathetic. Vasoconstriction symptoms below SCI. BP sky high like 210-170. Decreased HR. Below the injury equals cool, pale, no sweating. HA, blurred vision, facial flushing, distended neck veins, sweating, above injury. Jarring. Jarring. Sit up 90 degrees. Loosen clothing. Find the cause, could be distended bladder. Fecal impaction, tight clothing, burns, ulcers. Give antihypertensive. Call the physician if not effective. Symptoms of autonomic dysreflexia include flushing, sweating, a pounding headache, bradycardia, sudden and life-threatening hypertension, vision changes, goosebumps. Treatment should be immediate and may include changing positions, emptying the bladder or bowels, or removing tight clothing. If not treated immediately, autonomic dysreflexia can lead to seizures, stroke, myocardial infarction, and death. Autonomic dysreflexia is caused by irritation or pain below the level of injury. Methods to avoid irritation include regularly emptying the bladder and bowels. If using an indwelling catheter, keeping the tubing free of kinks and the drainage bag and tubes clean and empty. Treating urinary tract infections promptly. Consuming adequate fluid and fiber to prevent constipation. Changing positions frequently. Regularly assessing the skin for impaired integrity, including pressure injuries and ingrown toenails. Avoiding burns, including sunburns. Not wearing clothing that is too tight. Taking medications as prescribed to prevent pain and other complications that may initiate autonomic dysreflexia. Not becoming overstimulated during sexual activity. Pharmacological. High-dose methylprednisolone within 8 hours of surgery to improve neural function and reduce inflammation, hyperglycemia, hypervolemia, weight gain, mood changes, risk for infection. Prophylactic anticoagulants to prevent DVT. Mainly aimed at symptoms. Pain, constipation, infections, antibiotics for pneumonia, hypotension, muscle spasticity, non-pH arm. Point with SCI will require extensive care. Maintain airway. Prevent complications. Primary, urinary, bowel, GI. Secondary, related to immobility. Facilitating rehab. Gait training. Client education for home care. Therapeutic interventions, surgical treatments. After stabilization of the spine, they may immobilize the neck with a haloskeletal traction. Pin care is so important with this to prevent infection. Timing is controversial with surgical interventions, early versus late decompression. Surgery is performed to stabilize the spine. Bone grafts, external fixation or traction, Gardner-Wells method or halo brace.